Very good evening, everyone. At the outset, I would like to thank AIOS and my mentor, sir, is sitting here for this wonderful opportunity. My topic is less is more in the case of unifocal orbital eosinophilic granuloma. I'm going to take you through a case of a 30-year-old lady, a medical student, who presented to us with a swelling in the right eye, which was present in her for a period of 3 months. She said that it was associated with pain, which was more in the morning, and she had a course of antihistaminics and antibiotics before she presented to us, but there was no resolution. There was no significant ocular or systemic history, and there was no history of any diminution of vision, double vision, or headache, no history of trauma, fever, or allergy that was elicited. On examination, as you can see, there was fullness of the upper lid that was present. There was erythema that was present. Because of the lateral fullness, there was mild ptosis that was seen. The lateral orbital margin was irregular. There was fullness of the temporal fossa. Firm, tender, ill-defined mass was palpable in the temporal fossa. Finger insinuation and retropulsion was negative. There was no proptosis seen in this case, and ocular motility was free and full. Rest of the examination, as you can see, was almost within normal limits. Radiological examination, she was actually carrying a CT film with her, which was ordered by the referral physician, which showed a right-sided osteolytic lesion in the zygomatic bone associated with soft tissue component in the orbit and the temporal fossa, a typical triradiate lesion with lacrimal gland enlargement. We also, as you can see here, we also ordered an MRI, which corroborated with the findings of the CT with a hyperintense lesion in the lateral orbital wall surrounding soft tissue swelling and lacrimal gland enlargement. So at this point of time, provisional clinical radiological diagnosis for this case actually was a right-sided intraosseous lesion, and our differentials at this point were osteomyelitis, tuberculosis, that is, intraosseous dermoid with inflammation, or a eosinophilic granuloma. We went ahead with orbitotomy with exploration and excision biopsy with intraoperative frozen section. It was an uncomplicated lateral orbitotomy, and as you can see, intraoperatively, granulation tissue was seen with bony fragments, which was taken out. Frozen section was sent, which was suggestive of a histocystic lesion, and we were awaiting the final histopathological diagnosis and special stains, which came out to be negative. On histopathology, as you can see here, there were large epithelioid histiocyte-like Langerhans cells were seen on a polymorphous background. This is a magnified view of the Langerhans cells and the sheets of eosinophils. Immunohistochemistry confirmed the diagnosis of eosinophilic granuloma, wherein CD1A and S100 were strongly positive, as you can see here. We also went ahead with a systemic evaluation for her. PET CT scan was done and bone marrow biopsy, which came out to be negative. Hence, a final diagnosis for her was right-sided orbital unifocal eosinophilic granuloma, wherein the systemic examination was normal. She received right eye intralesional triamcinolone acetonide, 1 ml was administered. This is her picture after 3 months of triamcinolone injection number 1. And as you can see, radiologically also, the lytic lesion is seen in the zygoma, but bony remodeling has started. The resolution of soft tissue component can be very well seen here. Subsequently, she received the second intralesional triamcinolone acetonide injection, and at the last follow-up at 21 months, you can see beautifully the bone has totally, the bony remodeling can be fully seen. There's no lytic lesion seen, and soft tissue component has fully resolved. Hence, this is the presentation. This is her picture at the presentation, and this is at 21 months of follow-up. And as you can see, there is full bone remodeling and complete resolution of the disease that can be seen. I'll quickly touch upon the histiocytosis X, which includes eosinophilic granuloma, which is the most common of these presentations, and it depends on unifocality, multifocality, or acute disseminated disease, which can be Hand-Schüller-Christian disease, which is multifocal involvement, or Letter-Suez disease, which is acute disseminated fulminant disease. Eosinophilic granuloma amongst these is the most common. It has a male preponderance which presents in the first decade. It generally involves the frontal or the superotemporal bone. So the typical points that we saw in our case was that it was a female, well into her 30s, and a zygomatic bone was involved in her. A thorough systemic evaluation is mandatory in all cases of histiocytosis. Also, there are many treatment options available for Langerhans cells histiocytosis based on the systemic involvement, unifocality, multifocality, whether dura is involved or whether it's an aggressive disease, which ranges from biopsy with curettage, steroid injections, chemotherapy or radiation, or a multimodal management. It is the pathogenesis is actually a transient immune dysfunction which leads to cytokine-mediated proliferation of pathologic Langerhans cells. The osteolysis that we see is because of the interleukin-1 and prostaglandin E2. So the corticosteroids acts at this stage, and hence in a unifocal orbital disease, when no systemic involvement is present, the aggressive destruction that you saw actually responds very well to the intervention that was demonstrated in the case. Hence, in a unifocal orbital eosinophilic granuloma, less is indeed more. Thank you so much for your patience.